Good evening, everybody. Today, our topic of discussion is approach to chest pain. So, what are our learning objectives in the session? So, by the end of the session, all the participants should be able to differentiate cardiac versus non-cardiac chest pain. That is our primary goal. And identify life-threatening causes early and use correct diagnostic approach and avoid common pitfalls. We have to recognize pulmonary causes of chest pain, gastrointestinal cause of chest pain, musculoskeletal cause of chest pain, and psychogenic mimics. And also, we should be able to use correct diagnostic approach and avoid common pitfalls, which we will see in the following slides. And also, we'll have some case scenarios for you to understand how to assess a patient when they walk into your OPD or ER. So, chest discomfort is among the most common reasons for which patients present for medical attention at either an emergency department or an outpatient clinic. The evaluation of non-traumatic chest discomfort is inherently challenging owing to the broad variety of possible causes, a minority of which are life-threatening conditions that should not be missed. So that is our end goal here. When a patient walks into your OPD or ER saying, I have chest pain, the initial strategy is to differentiate if it is life-threatening or not, either for us to evaluate further or not. So it is helpful to frame the initial diagnostic assessment and triage of patients with acute chest discomfort around three categories. It is myocardial ischemia, other cardiopulmonary causes like myopericardial diseases, aortic emergencies, and pulmonary conditions, and the non-cardiopulmonary causes. So gastrointestinal causes are the most common causes of chest pain which present to you, followed by ischemic heart disease, then chest wall syndromes, followed by pericarditis, pleuritis, then pulmonary embolism. Then the rarer ones are lung cancer, aortic aneurysms, aortic stenosis, herpes zoster. So this is a very nice table which is given in Harrison, which is giving us a brief overview. First, we'll look at the table as a whole, and then we'll dwell into each and every condition which are important. Okay. So what are the among the cardiopulmonary cause of chest pain? What are the cardiac causes? First, most important cause is MI, myocardial ischemia, which we should not miss. Myocardial ischemia can be divided into stable angina, unstable angina, and MI. So MI again, non-ST elevation MI and ST elevation MI. So what is stable angina? So how does it present? The onset of chest pain is usually it is gradual. It won't be sudden, and it is precipitated by exertion or cold or any stress. And the duration of pain is around 2 to 10 minutes. And whereas unstable angina, there is an increasing pattern of pain which occurs at rest also. So stable angina, usually at rest they're comfortable, and only on exertion or exposure to cold or any stressful stimulus, which can be even a psychological stressful stimulus or a physical stressful stimulus, pain will precipitate in these patients. But whereas in stable angina, there will be a crescendo descendo kind of pain pattern. In unstable angina, it is usually only increasing pattern of pain. If it is a myocardial infarction, the duration of pain will last for more than 30 minutes. That is a very usually more than 20 minutes itself. It can be alarming. How is the quality of pain in these patients? They'll say there's a pressure kind of pain or tightness or squeezing, heaviness, also sometimes burning. And the location will be retrosternal, classically retrosternal. It can, again, there are a lot of atypical presentations, but mostly retrosternal. And radiation. So radiation often radiating to the neck, jaw, shoulder or arms, and sometimes even epigastric region. So radiation to the right shoulder and arm is more. Usually we think that if you have to suspect MI, chest pain radiating to the left arm is more specific, but actually chest pain radiating to the right arm and shoulder is more specific for MI, and chest pain radiating to both arms, then followed by radiation to the left arm. Fine. Then pericarditis. So pericarditis, the pain is usually variable. So it can vary from hours, it can last to days also, and maybe episodic. It need not be continuous. So usually the visceral surface and most of the parietal surface of the pericardium are insensitive to pain. Then how is pain occurring in pericarditis? Because of the relation of the pericardium to the pleural surface. Because of this pleural association, the discomfort of pericarditis is usually pleuritic pain, and it is exacerbated by breathing, coughing, or even change in position. So pericarditis, how is the quality of pain? It is pleuritic pain because of the association of the pericardium to the pleura. And they complain of sharp kind of pain. All these conditions we will see as we go, but this is a brief overview. Here also the location of pain is retrosternal. or towards the cardiac apex and may radiate to the left shoulder. And classical of pain in chest pain and pericarditis is they will have pain while lying in the supine position, and it will be relieved by sitting up and leaning forward. And in auscultation, you will hear a pericardial friction rub. Okay, and a pericarditis can be a complication of a lot of causes of pericarditis. If at all, if pericarditis occurs as a complication of myocardial infarction, so there will be an after a STEMI, after an ST elevation MI, if the patient has pericarditis in the first 1 week, we call it as early pericarditis. And if the patient has pericarditis after 1 week, we call it as late pericarditis. So in the early pericarditis, usually pericarditis we treat with NSAIDs and steroids sometimes, and colchicine also. But in the early phase, we should avoid giving NSAIDs and steroids. What are the vascular components? Acute aortic syndrome, pulmonary embolism, pulmonary hypertension. In acute aortic syndrome, it is how does it present? Sudden onset of unrelenting pain. They have a tearing or ripping kind of pain, knife-like sensation they complain of. And in the acute aortic syndrome, which is classically aortic dissection, if the anterior aorta is involved, it radiates to the anterior part of the chest. And if ascending aorta is involved, and if the descending aorta is involved, it radiates to the back between the shoulder blades. And that's why this classical presentation. So it is associated with hypertension and their underlying connective tissue disorders, and they will have a murmur of aortic insufficiency, and they'll have loss of peripheral pulses. Next is pulmonary embolism. So chest pain here will be sudden in onset, and here also it is pleuritic pain, and it may manifest as heaviness with a massive pulmonary embolism, and it can be often lateral on the side of the embolism. They have pain, and other symptoms be dyspnea, tachypnea, tachycardia, and hypotension. Patient who's bedridden for a long time, and in the hospital itself, they've been in the ICU or in the ward for a long time. Unexplained drop in saturation, unexplained tachycardia. You have to, and if the chest is clear, first thing we have to think about is pulmonary embolism. Pulmonary hypertension. Here again the onset is variable. And also it occurs mostly on exertion. Pressure kind of pain. Here the location is substernal location. They also have dyspnea. And then pulmonary causes pneumonia or pleuritis. So pneumonia causing pleuritis, and that is causing, so pneumonia, how are we getting chest pain? Because of the pleural inflammation, and that is causing the pain. So associated symptoms in pneumonia will be cough, fever, crepitations, dyspnea. Spontaneous pneumothorax. This is a sudden onset chest pain, again pleuritic pain. It is lateral to the side of pneumothorax on that particular side itself. They present with dyspnea, and they have decreased breaths. On examination, you'll have decreased breath sounds on the side of the pneumothorax. So what are the gastrointestinal causes of chest pain? Esophageal reflux, GERD as we call, gastroesophageal reflux disease, which is the most common cause of chest pain presenting to the OPD. It lasts for 10 to 16 minutes. They'll have burning kind of pain and substernal epigastric, and it worsens by lying down flat. So worsened by postprandial recumbency, and relief is present by taking antacids. So the catch is this is very confusing. Even in inferior wall MIs also, they have similar presentation. So it is very important for us to differentiate between them. An esophageal spasm, it lasts for around 2 to 30 minutes. They complain of pressure, tightness, burning, intense squeezing. It is a retrosternal kind of pain. This also closely mimics angina. But esophageal spasm, again, it gets relieved by giving NTG or calcium channel blockers. So relief by NTG, again, points are diagnosis towards MI. We might think it is an MI. Esophageal injury, it is again a prolonged duration pain. They'll have a squeezing kind of pain. So what sort of esophageal injury? It can be a partial tear in the esophagus, that is a Mallory-Weiss tear, or a full thickness tear, that is an esophageal rupture, which is called Borhave syndrome, and they present with hematemesis. So Mallory-Weiss tear you can pick up on a UGI scopy, but Borhave syndrome, because the esophagus is ruptured, we cannot do an UGI scopy. We need to do a CT. Peptic ulcer, again, the duration here is very prolonged, 60 to 90 minutes after meals, they complain of pain. So these are all actually epigastric pain, which comes around as chest pain. Again, burning kind of pain. Epigastric location is most common, substernal location, and there will be relief with food or antacids. Again, gallbladder diseases, which includes cholecystitis, biliary colic. They also have prolonged duration of pain and aching or colicky kind of pain. Again, the location is epigastric or right upper quadrant. They may follow meals or may subside spontaneously. pancreatitis also. It is epigastric pain radiating to the back. What are the musculoskeletal causes? Costochondritis, very common actually. So young female, chest pain, no comorbidities, this tenderness on palpation. Usually in the second and third joints, it is most common. So there's a variant of it called teeth syndrome. Sometimes they have swollen tender, warmth over the joint, and maybe reproduced by localized pressure on examination. But if there is tenderness on palpation, you don't have to always think it is costochondritis. Even in an MI also, if you palpate the chest, patient may complain of pain. Cervical disc disease, again, the onset and duration, it might be very variable. Aching pain, it is usually this neck pain. They also complain of neck pain and radiating to both the arms. They'll have numbness in both the arms. That's how they present, apart from chest pain. And this is always exacerbated by movement of the neck. In trauma or strain, usually constant aching kind of pain. It is localized to the area of strain, obviously, reproduced by movement or palpation. Herpes zoster is again a very important entity. Prolonged pain, it is a sharp or burning type of pain. They have a dermatomal distribution. And sometimes pain can precede the rash. So first patient will have pain and then later they'll have a vesicular rash in that particular dermatome. And like post-herpetic neuralgia is a condition where patient presents with pain 30 days after the onset of rash. Psychological reasons, emotional and psychiatric conditions, again the variable onset of pain. It may be prolonged. So there will be history of panic attacks or history of depression. Patient may have, they might come to you with a long-standing history of consuming sleeping pills, which people mostly tell. So when you hear such kind of history, a young female or a male, no other comorbidities, their vitals are stable, normal blood pressure, normal heart rate, ECG is normal, then you have these other, you have to look into other factors which will help us point us towards the diagnosis. So considerations in the assessment of the patient with discomfort. This is more like a risk stratification. So could the chest discomfort be due to an acute, potentially life-threatening condition that warrants urgent evaluation and management? So what are the conditions which will require urgent evaluation and management? One is an unstable ischemic heart disease. Second is aortic dissection, then a pneumothorax and a pulmonary embolism. So these should not be missed at any cost. I mean, none of this should be missed, but we have to exclude this. So in the order of risk, this table is given. If not, could the discomfort be due to a chronic condition likely to lead to serious complications? That is stable angina, aortic stenosis, pulmonary hypertension. This is one step lower to the other causes. If not, could the discomfort be due to any acute condition that warrants specific treatment, like pericarditis? You might need to give NSAIDs or colchicine. Pneumonia, pleuritis. Why is it important to differentiate? Because you'll have to treat them with antibiotics. And herpes zoster, you might have to treat them with acyclovir. So yeah, if does it warrant any specific treatment, we'll have to rule them out. If not, could the discomfort be due to any other treatable chronic condition? So lesser risk conditions are these: esophageal reflux, esophageal spasm, peptic ulcer disease, gallbladder disease, other GI conditions, and cervical disc disease, arthritis of the shoulder or spine, costochondritis. So why this topic of chest pain matters? So chest pain is again the top 3 reasons for an ER or OPD visit. So early recognition of an acute coronary syndrome saves lives, and our goal is to recognize no ACS patient should be missed when they present you in an OPD. It can take, I mean, you can do whatever possible, but we should not miss any patient coming to your OPD or ER with chest pain who has ACS. They should not walk back and then come back next day with an MI. A lot of times patients present with very non-specific complaints. They might say discomfort, vague discomfort, a little bit of nausea. Every atypical pain should be respected. So whenever they say chest pain, you have to take an ECG no matter what. 30% of cardiac cases are missed initially because they might present a little bit of burning or nausea. So they are just like, given some PPIs and sent off. And the next day they're present with an MI. Sometimes they're just gone. So most chest pains are non-cardiac and they need careful evaluation. Pain may arise from the heart or aorta. And where are the sources when they say of chest pain? So where is the source of pain? Either with the lungs, maybe like pneumonia, then pleuritis, esophagus or stomach, chest wall muscles, ribs, or nerves and skin. So localizing the source of pain is our first diagnostic step. So this is exactly what we've seen on the table just now. We're going to study them elaborately. So categories: cardiac pain, they could be ischemic or non-ischemic. Non-ischemic consists of pericarditis and myopericardial syndromes and also aortic syndromes. Then pulmonary causes like pneumonia, pleuritis and all. GI causes like esophageal spasm, GRD, esophageal rupture, pancreatitis, gallbladder syndromes and all. Then musculoskeletal like costochondritis, psychogenic like panic attacks, which we've seen just now. And miscellaneous causes includes herpes zoster. So in the cardiac categories, you have acute coronary syndrome. So stable angina or chronic stable angina is not included in the spectrum of acute coronary syndrome, because stable angina, there is a fixed plaque. The fixed plaque, fixed limitation of blood flow, and symptoms, they're completely fine at rest. So only on exertion, they develop symptoms. Either it could be a physical exertion or any psychological stress which will precipitate the anginal event. And in the acute coronary syndrome includes three entities: unstable angina, ST elevation MI, and non-ST elevation MI. And then you have pericarditis, myocarditis, and aortic dissection. These are the cardiac causes. So what are the clinical clues suggesting cardiac pain? You see heavy pressure-like pain or central left-sided chest pain, radiating to the arms, jaw, neck. Like I told you, radiating to the right arm and shoulder is more specific to an MI, more likelihood of being an MI, followed by radiation to both the shoulders, followed by radiation to the left shoulder and arm. Then associated symptoms like sweating, nausea occurs on exertion or at even rest also. At rest, acute coronary syndrome occurs at rest. And on exertion, we're trying to rule out stable angina. So the typical chest pain, which this terminology is not used anymore, but then when somebody says chest pain, what are the things that you're supposed to be asking? So again, duration of pain, very, very important. So more than 20 minutes or like hours together. If patient says I'm having chest pain since 3-4 days, so probably unlikely to be an MI. Still we have to rule out, but then doesn't point out towards it. Recent origin, that is like hardly half an hour, an elderly patient, or even nowadays age doesn't matter. Even 20-year-olds are getting an MI. Comorbidities like hypertension, diabetes, or even if they're not hypertensive or diabetic, they could be alcoholic, smokers. Smoking is a huge risk factor for acute coronary syndrome. Even young males or females who are alcoholic smokers without any comorbidities like hypertension, diabetes can have excessive risk of developing an MI. So when they present you with a chest pain, you will first ask duration, and then you will ask quality of pain. Like what if they tell you if it's like a heavy pain, or classically they won't tell you like I'm having a pressure kind of pain. They can come out with very, very vague terminologies. Usually if they pinpoint on the chest and say here I'm having pain, like they point towards a specific location and say I'm having pain there, they say it is unlikely to be an MI. But still you cannot say. You have to take an ECG anyways. But before even taking an ECG, to understand the situation, then you ask about radiation. Is it radiating or not? Then radiation, like we spoke, radiation to the right arm is more specific. Then followed by both arms, followed to the left arm, radiation to the left arm, and to the jaw and to the neck also. Then associated symptoms should be asked. Is it associated with shortness of breath? Is it associated with nausea or sweating? Or is it associated with palpitations? Is it getting worse by walking or any sort of exertion? These are the questions you should be asking. These are the clues which will guide us to achieve a diagnosis faster. So what are the red flags which need immediate action? So chest pain with breathlessness, or chest pain with sweating or syncope, or if they present you with hypotension, chest pain and hypotension, maybe they went into cardiogenic shock. Then a sudden tearing pain radiating to the back. This is more classical of aortic dissection. Or if there's an ST elevation on ECG, again, that is also alarming. These are all red flag signs which should make you act quick. Do not waste time. Call the if you're suspecting anything like this, then call the cardiologist, get an echocardiogram, send cardiac enzymes, and evaluate further. So approach a suspected cardiac chest pain. So rapid assessment, you look at the airway breathing circulation, then you do an ECG within 10 minutes. Within 10 minutes, ECG should be done. And then you send cardiac enzymes, tropi. Then oxygen, if you connect to oxygen if SpO2 is less than 94% only. Otherwise, no need to put them on supplemental oxygen. And risk stratification, after seeing the ECG, you can think about it as if it is ST elevation MI, you have to either thrombolize or refer to a cardiologist for a primary PCI. If it is a suspicion of a non-STEMI, non-ST elevation MI will occur if there are diffuse ST depressions or T-wave inversions, and if the cardiac biomarkers are elevated. So a case like this comes to your OPD, suppose a 56-year-old diabetic man with crushing retrosternal pain, radiating to the left arm, sweating, and nausea is also there. This is very classical. There's nothing to miss in this. It is the chest pain and the associated symptoms are all fitting towards a ischemic event. Radiation is there to the left arm, sweating is there, nausea is there. He's already a diabetic. So, and then on ECG, you're seeing ST elevation 2-3 AVF. In these leads, you're seeing ST elevation, and also the reciprocal leads will have ST depression and T-wave inversion. ECG and all that is beyond the scope of today's class, but we'll discuss in acute coronary syndrome will be another topic of discussion. Then you'll understand better. So this point out towards, this is a case of inferior wall MI. He needs to be thrombolized or taken up for a primary PCI. Again, management we'll discuss in detail in the following classes. So, but what are we supposed to do if you're picking up an acute MI? What should you immediately do is to give a loading dose. It consists of aspirin 325 mg, clopidogrel 300 to 600 mg, or ticagrelor 180 mg, or prasugrel 60 mg. And prasugrel should to be given if no prior history of stroke or TI is there. And then anticoagulate them with heparin or enoxaparin. Along with this, a high-intensity statin also to be given. That is atorvastatin 80 mg, rosustatin 40 mg. So nitrates to be avoided in inferior wall MI and also RVMI because they can cause hypotension. Then AC inhibitors, beta blockers only after stimulation. If they're coming in cardiogenic shock, not supposed to give beta blockers. After your job is to give loading dose, take the ECG, diagnose an MI, give the loading dose, and refer to a cardiologist. So what are the types of angina? Stable angina, like we've studied. There'll be a predictable course, and you'll have pain only on exertion, and it is relieved by rest or nitrates. There's a fixed plaque and a fixed limitation of flow. Unstable angina, again, new onset pain, and it is a worsening. So it is a worsening kind of pain, so it is an emergency. And variant angina is because of coronary spasm, and they get relief on giving calcium channel blockers actually. Another case scenario, a 45-year-old female who has burning pain after meals, and she complains, she comes to you with presentation of burning sensation in the epigastrium and the chest soon after meals, and then ECG is normal. You do a cardiac enzyme that is also negative, and it improves with PPI. So most likely it has to be GRT. So STEMI, again, ST elevation more than 2 contiguous leads, like either inferior leads or anterior leads or lateral leads. Again, ECG and acute coronary syndrome is a topic of discussion in the later sessions. So NSTEMI will have, so STEMI will be localized. So you will have the inferior leads or anterior leads. NSTEMI will have, it is not localized. ST depression inversions can be diffuse. And there will be troponin elevation both in ST elevation MI and non-ST elevation MI. So differentiation between non-ST elevation MI and unstable angina is a normal troponin level in unstable angina. So then what happens in unstable? You're saying normal ECG and tropi. You can ask me then what exactly is it? So they will have chest pain, and it will be classical, like radiation to the left or right arm, and then with nausea, sweating, palpitations, typical chest pain. But normal ECG, they might or might not have regional wall motion abnormality on the echo, and there will be no elevation of troponins. But you're treating them like a acute coronary syndrome only. These patients also, they also require anticoagulation, they require dual antiplatelet statin, and they require an angiogram. So troponin pattern of elevation normally takes 3 to 6 hours after the symptom onset to rise. So if chest pain history is less than 3 hours, please repeat after 3 hours also. Immediately they might not rise. And then it peaks in 24 hours and stays elevated 7 to 10 days. In myocarditis, there will be a viral prodrome, and then fatigue plus chest pain. ECG will have non-specific STT changes, and management will be supportive management. Usually you avoid NSAIDs in the acute setting because it might impair healing of the myocardium. Then pericarditis, they have usually a sharp pain. It is worse on lying down and better on sitting forward. So ECG will show diffuse ST elevation and PR segment depression. You can give NSAIDs and colchicine. Again, pericarditis, like I said, as a complication of ST elevation MI, if patient has pericarditis, there are 2 types. early and late pericarditis. Early pericarditis is within first week of having your STEMI. And in that phase, do not give NSAIDs or steroids. You can just increase the dose of aspirin in these patients. And the late pericarditis is usually after 1 week. It is called Dressler's syndrome. It's an autoimmune condition. And there you can give them NSAIDs. Next is aortic dissection, symptoms and management. They'll have a sudden tearing kind of pain radiating to the back. They present with unequal, asymmetrical pulse, asymmetrical BP, sharp tearing kind of knife-like sensation, tearing pain radiating to the back. And on chest X-ray, you see a widened mediastinum. Usual causes hypertension. There can also be other causes like any connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome. All of them are risk factors for developing aortic dissection. So if the ascending aorta is involved, you'll have pain in the anterior part of the chest. And if the descending aorta is involved, you will have pain radiating in between the two shoulders. So if the dissection begins in the ascending aorta and goes to the descending part of the aorta, that's why the classical presentation of anterior chest pain in the anterior region radiating to the back in between the two shoulder blades. What do you do in this patient? Emergency treatment, you lower the blood pressure, you give IV labetalol or esmolol. That is one. And then they will require surgical correction. So if the ascending aorta is involved, they will definitely require surgery. And there are different classifications of systems in aortic dissection as to how to operate and correct them. Non-cardiac causes. What are the pulmonary causes? Pulmonary embolism we've seen previously. So it is a sudden onset of chest pain. The pneumothorax also sudden onset. Chest pain usually localized to the side of the pneumothorax, and then you'll have absent lung sounds on that side. Then pleuritic pain and pneumonia. Pneumonia also causes, because of the pleuritis only, getting chest pain and pneumonia. So again, pneumothorax, you have primary spontaneous pneumothorax is rare. It is rare, but then risk factors are usually young males, smokers. They have a family history of pneumothorax, or if they have Marfan syndrome, they're all risk factors for primary spontaneous pneumothorax. Secondary spontaneous pneumothorax, on the other hand, patients already have underlying lung disorders like COPD, asthma, cystic fibrosis, and then tension pneumothorax. 3 types. So pneumothorax, you have primary, secondary, and tension. Tension pneumothorax is again a medical emergency. It is caused by trapped intrathoracic air that precipitates hemodynamic collapse. So most of the pulmonary diseases which cause chest pain, including pneumonia, the malignancy, are all because they involve the pleura. So that is a pain-sensitive structure there. So how is the pleurisy described? It is mostly like a knife-like pain that is worsened by inspiration or coughing. So knife-like chest pain worsened by inspiration or coughing is characteristic of pleuritic pain. Again, a case study. 35-year-old postpartum with sudden onset dyspnea, pleuritic pain, ID dimers, pulmonary embolism is in this scenario, likely to be pulmonary embolism. So what do you do? A CTPA to rule out pulmonary embolism, then you anticoagulate them. Pneumothorax, again, sudden onset, one-sided pleuritic pain, you have decreased breath sound, chest X-ray will visible pleural, and management is with needle decompression or putting an ICD. Pneumonia, so the symptoms like we've seen, they have fever, cough, dyspnea, pleuritic pain. On chest X-ray or a CT, you might see a consolidation, or if it is viral pneumonitis, it could be GGOs. Treatment, usually carbapenems. If it is an OPD presentation, you can give them amoxiclav or a third-generation cephalosporin, or even IV antibiotics, depending on the CURB score. So again, GI causes, GRD, which is the most common cause for presentation to OPD, esophageal spasm, peptic ulcer disease, biliary colic, pancreatitis. Pancreatitis pain is epigastric pain radiating to the back. Then peptic ulcer, again, it starts 60 to 90 minutes after ingestion of food. Esophageal spasm, like I said, 30-minute duration of pain usually. It is retrosternal pain. It can mimic angina, and it is relieved on giving nitroglycerin or calcium channel blockers. So that's why it mimics angina. GRD is classical. These water brush kind of symptoms, patient can say they have a reflux, like some sort of metallic taste. Some patients might complain. Classically burning kind of sensation, aggravated after a heavy meal or after immediately lying down after a meal. So spasm, like I said, it is a squeezing type of chest pain. ECG will be normal. It is relieved by nitrates and confirmation by esophageal manometry. So musculoskeletal causes costochondritis or trauma. So fibromyalgia, patient may have very, very non-specific symptoms. They'll have pain all over. They'll have a lot of muscle pains, and they can also have chest pain. Another clinical case here. 28-year-old female, localized reproducible pain at rib junction. Serial ECGs are normal. The serial ECGs are normal. Tropa is negative, including the repeat after 3 hours.
Osteochondritis.
Yeah. What's your name?
My name is Tejasvi.
Okay, very good. So you give them NSAIDs and advise some exercises. Psychogenic causes anxiety, like panic attacks. So around 10% patients come into your OPD with chest pain with SOB. They might be having SOB also. It probably might be due to a panic attack. So correct history taking is extremely important. Invariably, you have to order an ECG for all patients coming with chest pain. Not only chest pain, some sort of vague epigastric discomfort, unexplained nausea. All these patients, just do an ECG to be on the safer side. Especially elderly patients with comorbidities, definitely you should be doing. Another case, it's a 23-year-old female chest tightness, tingling fingers, normal ECGs, repeat ECG also is normal, Tropa is negative. So this is likely to be a panic attack. So these patients' panic attack, they're usually present with numbness and tingling of the fingers, feet also. They're very vague symptoms. Extremely important questions to be asked in these patients are, one is drug history and sleep pattern. So now they might be presenting to you with a panic attack. So if they have to come to your OPD or ER with a panic attack, that means they have a past history of depression or anxiety. So even if they do not reveal everything about what they're experiencing, you should ask about their appetite, sleep, drugs, what they consume, what are their routine activities like. So these will all give you clues to diagnose. For these patients, you ideally put them on SSRI or ideally let them consult a psychiatrist. Another case, 55-year-old male with sharp burning chest pain, then the vesicular rash next day. I think this is very easy. Zoster. Yeah. And then you give acyclovir. It's a type of pain, give pressure or heaviness, squeezing type of pain, sharp pain, stabbing or pleuritic pain, burning, retrosternal, localized or sharp. So relation to breathing, again, if it was a pleuritic kind of pain, there will be it increases and aggravates on inspiration. Again, radiation. These are all characteristic of the pain which are supposed to be asking, associated symptoms. So is there any radiation or not? And is there any tenderness and palpation or not? Then associated symptoms like sweating, nausea, dyspnea, syncope, tachycardia, sour taste and regurgitation is because, like I told you, those water brush kind of symptoms, they occur in GERD. So they're all clues for you to pick up what actually it is. Then ECG can be abnormal or normal because the STT changes. And is there a relief with antacids or yes or no, you're supposed to ask. So approach should be, first you look at how stable the patient is. Airway, breathing, circulation, it goes without saying. General condition of the patient, when they come to you with hypotension, tachycardia, or desaturation, obviously it is alarming. Then you rule out cardiac causes first. You do an ECG, do an echo if it's available, send cardiac enzymes, and identify life-threatening causes. Then if once the we've seen in that 4-step approach, what are the life-threatening causes which require urgent treatment or evaluation, followed by then you evaluate if there are any GI causes, musculoskeletal causes. So treat the cause, first treat the symptoms, and then find out the cause and treat the cause. So within 10 minutes, we need to do an ECG, that is non-negotiable. Then Tropi over the next 3 to 6 hours, chest X-ray, D-dimer. If you're suspecting a pulmonary embolism, send a D-dimer. And all the routine investigations, CTPA also if you're suspecting a pulmonary embolism. And echo to look at any regional wall motion abnormality or to look at how there's any valve abnormalities. So this is a case which was an NSTEMI but missed in the OPD. So a 50-year-old male treated for gastritis, which is very, very common due to burning kind of pain. 50-year-old male walking to your OPD with a burning sensation in the epigastrium or the retrosternal region. They might think it is a peptic ulcer or some GERD. They just give them on pantoprazole and send them off. They don't do an ECG. And then next day, at least this patient came back next day to get an ECG done in props, and sometimes they don't even turn up. They might just die. Always consider ACS in diabetics even without typical pain because they have autonomic neuropathy. Diabetics may or may not have a classical chest pain history. So women also might have a lot of atypical symptoms. So there's something called angina equivalence which we look into, like nausea, vomiting, diaphoresis, sweating, dyspnea. So any other atypical symptoms, so like I said in the beginning, every atypical symptom has to be respected and you need to do an ECG for it. Anything can be an ACS. ECG may be normal early, but then again, serial ECG monitoring is extremely important. If one ECG is normal, you're not ruling out an ACS. First, based on your history, you should first, in your mind, you need to do a risk stratification in your mind itself. Look at the age. Again, like nowadays, age is not a criteria. Even young people are getting MIs. But above 40 years, suppose 40-year-old male or female, more common in males, and then who's a diabetic. If they're so diabetes is called an angina equivalent. Why? Because if they are having diabetes, they're already developed macrovascular risk for macrovascular complications already there. So if a patient had to become diabetic at 30, I'm talking about type 2 diabetes, especially at diabetic at 30, from 20 or even earlier itself, insulin resistance would have started from many years before them turning out to be a diabetic. So from the time patients are having insulin resistance, they have a risk for macrovascular complications and diabetes, which includes stroke, MI. That's why if patient is a diabetic, that itself is an enough risk factor for them to have an MI. Also hypertension, but diabetes more than hypertension, and alcohol smoking. So management overview. It's a cardiac symptoms pointing out like pressure kind of pain, ECG showing you like ST elevation or ST depression, T wave inversion, then proper being positive. Then you load them with antiplatelets and anticoagulate them. Either if it is an ST elevation MI, do a lysis, or if there's a cardiologist available, send them for a primary PCI. Pulmonary causes. If again the pain is like sharp pleuritic pain, on an X-ray you might pick up a consolidation and pleural effusion, that causing pleuritic pain, or a CTPA to diagnose a pulmonary embolism. You give them oxygen, anticoagulation in terms pulmonary embolism, or an IC. GI causes like burning kind of pain usually. You do a PPI trial, then lifestyle changes, weight loss, abstinence from smoking, alcohol, avoid heavy meals. These are the things you're supposed to tell them, patients especially who are having GRD. Musculoskeletal causes, reproducible pain on palpation and on thorough clinical exam is very important. Give them anesthetics. So this is the OPD algorithm. In ECG vitals, if they're normal, then you check for all the red flags. Pleuritic pain, think of lung causes, PE or pneumothorax or pneumonia. Burning pain, the same thing actually, present in a different way. Localized tenderness, musculoskeletal causes. Persistent unexplained causes, then you refer to a cardiologist for further evaluation. See the red flags. Chest pain more than 20 minutes. If it is pointing out towards an ACS, mostly an MI. Then if they present you with hypotension or shock or a new murmur, like complications of MI, especially ST elevation MI include ventricular septal rupture and acute mitral regurgitation. That is, the acute MR is due to the papillary muscle rupture in STEMI patients. So that will give you a pansystolic murmur. That's why new murmur in auscultation. It's very rare that people auscultate in the ER, but it is extremely important to pick up, at least if you cannot differentiate between different kinds of murmurs, something you're hearing something which is normal. At least S1, S2, most people will know how to differentiate. Everybody, in fact. But murmurs is difficult to pick up, but anything abnormal, if you're on auscultation, again, it will help you in your diagnosis. If they're coming to you with severe dyspnea or SpO2 less than 90, or if they present to you with syncope, all these are red flags. So preventive measures for ischemic heart disease, usually you have to control their blood pressure, control blood sugar is very, very important. And also lipid profile management, regular exercise, stress reduction, no alcohol, smoking, weight management. This is the routine advice you give to all your patients. So what are the pitfalls? Now, treating chest pain as gastritis without an ECG, like how we saw, especially most of these inferior wall MIs present with burning sensation in the epigastrium and the retrosternal region, so they can be missed as gastritis. Missing silent MI in diabetics. They don't come with chest pain because it is silent because of the autonomic neuropathy they have. Then ignoring atypical symptoms in women, like I told about the angina equivalents. And then overprescribing PPIs and anxiolytics. So every chest pain, little bit of SOB, so anxiety should be the last thing you're thinking about. Unless you rule out an ACS, nothing else should be diagnosed. And not all chest pain is an MI, but you have to rule out that first. When in doubt, even if you're not in doubt, just do an ECG. Yeah, advised chest pain is cardiac until proven otherwise. ECG is mandatory for all chest pain patients. Pulmonary causes may mimic MI. GI and musculoskeletal causes often misdiagnosed as cardiac issues. Rule out emergencies early and treat the rest rationally. So this is a differentiation table. So in classic MI, you see ST elevation, and then what you do loading dose of antiplatelets, anticoagulation, and refer them for PCI. And GRD, you'll have all these already we've seen. Same table is being repeated again for better understanding. GRD usually have post-meal burning, then you a PPR trial you do. Aortic dissection, they're present with acute onset chest pain radiating to the back, knife-like tearing kind of chest pain, unequal asymmetrical BP, asymmetrical pulses. Points out towards aortic dissection. If the BP is elevated, control BP. Pulmonary embolism, they have unexplained tachycardia, dyspnea. You do a D-dimer and then send them for a CTPA. Musculoskeletal pain, again, reproducible pain on palpation, give NSAIDs. Panic attack, they'll have tingling, sensation, numbness, history of depression probably. So for them, SSRIs or some breathing training, and then a psychiatry referral. Herpes zoster, so the pain can precede the rash. So treatment again will be acyclovir.
Ma'am, can you explain us the NT-proBNP results? Well, when we have a patient in the ER, nowadays doctors are asking to prefer NT-proBNP instead of ProPI.
No.
Can you explain us on that?
Yeah, sure. So NT-proBNP is a predictor for heart failure. So patients, even a patient with the anterior wall MI can come to you with a heart failure. So that is not a replacement for a troponin. So usually more than 900 is significant enough to consider the patient has heart failure. Again, heart failure is of two types: heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So if your patient comes to you with dyspnea, crepitation, speedal edema, you want to without doing an echo itself, if you want to find out the cause, then you send an NT-proBNP, and it has a higher negative predictive value. So if NT-proBNP is negative, then it is unlikely to be heart failure. It's more like that. It is not a replacement for troponin. So troponin is to look at myocardial injury.
Okay. What are the chances that having the false tropi levels in
It is a comprehensive assessment. You look at, you're not relying, again, you do not do troponin values in all patients. You should have a strong clinical suspicion first. First symptoms, then ECG, then along with ECG only till you get an echo, do cardiac enzymes. And they should be rise and fall of these enzymes. That is extremely important. So if you have myocarditis patient, they also can have elevated cardiac enzymes. So how do I know if it is ischemic or not? They should have ischemic symptoms first. So again, this is a collective analysis. Do not do randomly. If a fever patient comes, you do tropi, it comes elevated, you don't know what to do with it. So don't order investigations without clinical suspicion.
Okay, ma'am. Thank you, ma'am.
Okay. Any other doubts also, you can write to me. My email ID will be provided. We can also make a WhatsApp group and make it interactive.
Yes. Thank you, Doctor Namratha. Such an informative session. Yeah. Thank you, team.